Half day, everybody. So we'll have everyone start coming back in from lunch now, but since we are at 1:30, I want to start everything on time. And the first thing I want to do is, I know I didn't have the QR code up for earlier when Barry Dunn was here. So if anyone didn't have the opportunity to access the QR code and answer the survey, I'll leave this up before the presentation for a few minutes. And please, everyone, scan that and take part in that survey. And then also before we are able to do this, be able to start up, I just want to bring someone here who has been the main support for me and getting our work for the coalition going. Big support for homelessness on Guam and everything that we've been doing the past 7 years. So if I could bring up the Lieutenant Governor, Josh Tenorio, give some words.
Thanks, Rob. I just wanted to thank everybody for all the things you're doing out there individually, collectively, within your organizations as volunteers, to everybody that's living the experience and that's helping to maybe inform our strategies. I just want to also say thank you. I know that we have a significant amount of challenges on the island, but I'm just confident that when we can get together and talk to each other, figure out where we can help each other, identify what are all of the wins that we have. We have some wins, but also, give us a path on where we should go. This is not a very easy issue, we have to try and tackle, especially for people that are living out there that are unsheltered or not in a stable home environment. A lot of people have a lot of challenges, but in our community, what makes our community, I really think, much more special than most is, actually do care about each other. Maybe we need to go back to basics when the times where we know who our neighbors are, who our family members are, be interested in their lives, really trying to understand how people can empower themselves, right? That's really what this is about. I'm just looking forward to hearing about all the different work that we're doing, but I'll just leave you with, I really do think that a lot of people need help out there, but I really always like to, we should also give some extra focus and attention to the youngest people in our community, all those kids that are growing up in the world. When we are giving them the philosophy and showing them love and how it means to care for people, we're really doing a big thing for the island. That is really what is so critical. We need to know who each other are. We need to care. In this world, sometimes we maybe get distracted. Sometimes we get angry at each other. Sometimes we may think that our problems are insurmountable. But we should always have hope that there's always going to be a better day. And sometimes, it might not appear that it's in front of you, but when other people are there, I think that we're able to really help each other. So I look forward to hearing everything. I came today because, a lot of people are in crisis. So I wanted to listen, see what our strategies are at behavioral health, see how that we can inform all the work that we do with each other. So congratulations to everybody. Have a great day, and thank you again for everything that you're doing. Si Diyos Masi.
test. All right, good afternoon, everybody. Just trying to testing this mic volume here. Thank you, LT, for your kind remarks and your care for the community. I also want to thank Chief Rob of DHAP for inviting us to come out and present our services. My name is Mark Torrey Jr. I'm with Guam Behavioral Health and Wellness Center's Mobile Crisis Response Team. And today we have supervisors of our crisis continuum services. So we've got our 988 Lifeline, Mobile Crisis Response Team, intake, our stabilization units, and our assisted outpatient treatment program. And what we want to present today is what we call our crisis call through activation and admission. The big takeaway that we hope we leave you guys with today is that, you know, when you're in a crisis or anybody around you, your neighbor, your family member, somebody on the streets, we want you to know that there's always somebody to call, which is our 988 team, somebody to respond, which is our mobile crisis response team, and somewhere to go, which is our stabilization units, our main facility, and our intake team at the main facility. So again, we hope that that's the big takeaway with today. Here's our agenda. We'll go through some introductions, some terms and definitions that we use in the field. Each section will present their mission and capabilities, our information on our admissions, our voluntary and involuntary, the stabilization process, and then also the internal process, crisis call through admission. So we'll go ahead and go with some introductions. You guys all know who I am now.
Half day, everybody. My name is Jesse Libby, and I'm the project director of the 988 Lifeline under the Guam Behavioral Health and Wellness Center.
Half a day, I am Carla Torres Haddock. I am the provider at Guam Behavioral.
Hi, everybody. My name is Alyssa Roberto. I'm the project director for Guam System of Care, which is the intake division.
And who unfortunately could not join us today is Ms. Mermaid Williams, who is the project director of our AOT, Assisted Outpatient Treatment Program. However, we will have Dr. Carla able to cover down on her portion, so you guys are aware of the services. So here are some terms and definitions as we jump into this. When you hear GBWIC consumer, that's basically our professional term for a client or a patient or somebody who is availing of our services. 988 Lifeline specialists are trained telephone and text operators who can support you through your crisis and act as our primary dispatchers, which is the mobile crisis response team. And Jess will get more into that. Our mobile crisis, our MCRT crisis specialists are persons who either have a bachelor or master's degree in mental health or related field and who are trained to provide crisis outreach intervention to the community. Our MCRT peer intervention aid are persons with lived experience, and it's back through research that persons with lived experience can often express that rapport building when integrating with persons with similar experiences and life challenges. Mental health crisis is a situation where a person's behavior or mental state put them at risk of potentially harming themselves, others, or unable to perform or function properly or regularly in life. Serious mental illness are those illnesses that are diagnosed with our DSM-5, which is a manual that clinicians use to aid their clinical impression in developing a mental health diagnosis. Some common ones that many of you have probably heard are schizophrenia, bipolar, major depression, a major depressive disorder, generalized anxiety disorder, PTSD, things of that nature. And serious emotional disturbances are similar in that, however, it's more specific to children and adolescents. And then substance use disorder is any substance, whether legal or illegal, that impairs one's functioning.
All right. All right. So the 988 Suicide and Crisis Lifeline, if I can just ask the crowd, how many of you are familiar with 988 services? All right, cool. Speaking to the choir, so that my presentation's done then. So the 988 Lifeline is, next slide, please, is the National Suicide and Crisis Lifeline. It was established through a federal statute back in 2020 and was signed by President Trump back in 2020, which mandated each state and territory to merge into a easy to remember 3-digit line known as 988. And that will be known for individuals experiencing a mental health crisis to access services. Typically, each state and territory had their own crisis lifeline before. Ours was 647-8833 here in Guam. And then no matter, depending where you were at in the States, they had their own numbers to call. But they knew that there was a gap in the system, that we needed an easy to remember 3-digit line like 911 when you have a medical emergency or a safety issue. So 988 started back in 2020, which mandated each state and territory to merge and to start in 2022 of July. Guam took that federal law and successfully implemented 988. Till this day, when I speak to our federal partners, Guam has is input in high regards because we had one of the most successful implementations of this line nationally. In fact, there are some jurisdictions in the states that still struggle with starting their lines up. And so Guam is in a really fantastic place with regard to 988. We are also in a fantastic place because 988 is part of the continuum of care in the crisis continuum. And that's part of the goals and objectives of when SAMHSA first launched 988 was to start these programs and merge them into it. And Guam really was in a good place because when a person calls 988 and is needed for interaction, in-person interaction, Mark is literally right next door. And so we're in a really good place with regard to our implementation. So, so one thing about 988 is how many of you are familiar back in the day when we could easily just call 7-digit number when we're calling locally? Remember those days? Yeah, I apologize because we're the result as to why everyone has to dial the 671 code. And it's for good reason, though. Guam statistically has high rates of suicide, and suicide disproportionately affects people, mostly in our community, disproportionately. And so, what's one of the strategies in helping bring down those suicide rates or addressing mental health crisis is to expand access to critical interventions, and that's what 988 is. So 988 offers free, confidential, 24/7 access to a lifeline specialist. And so anybody can call if you have thoughts of suicide, mental health, or substance misuse crisis, or any other kinds of mental health distress. And so we offer a bunch of, we offer that listening, non-judgmental, that ear. Oftentimes, for a person who feels a certain way, we kind of put our ego in front of us. We kind of think that people are going to judge us right off the bat for how we're feeling or what we're feeling. I can promise you 988 offers that free, non-judgmental listening ear. And so feel free to call us, chat, or text us. Next slide, please. So these are some of the components of what 988 is. This is what the scope of services that we provide. We offer active listening. What is active listening? Hearing the caller out, hearing for what they're feeling for what it is. We don't judge person for what they're feeling. We listen to them. We also do safety screening. What is safety screening? Ensuring that you're in a safe environment. If you feel like you are in a place that is triggering you to feel a certain way, we can offer guidance on what to do. We offer suicide screening, and suicide screening is often not a topic that is very easy to talk about. Uh, we know in our culture, talking about thoughts of suicide or harming yourself or others really is a difficult conversation to have. My team is incredibly trained on how to navigate these difficult conversations. And we offer safety planning. What is safety planning? In the event that you feel like a caller calls and they are not, they're feeling a certain way, each caller is offered to go over a safety plan. A safety plan is an individualized plan on what the caller can do in the event that they feel triggered by certain things. And this is something that we offer to each and every caller that accesses 988 services. De-escalation techniques. My team is incredibly trained on how to navigate those conversations and how to de-escalate. In the event that de-escalation can, it can no longer be done over the phone, we have other services like the mobile crisis response team that we can access to. Substance misuse screening. Earlier today, we heard DOC and the judiciary talk about high rates of drug misuse. We offer drug screening and to ensure that the person, number one, is safe, and number two, they have the resources out there in the community and how we can link them to those proper services. Wellness planning. Wellness planning. How many of you are familiar with this wellness plans? Okay, so wellness planning is something that we like to do with callers because we know stress triggers people to feel a certain way. And what we do is we individualize a wellness plan in the event that certain triggers or certain emotions come up from a person. We create strategies on what to do, safe strategies on what to do when they feel a certain way. Referrals into the community. Part of what 988 does is hearing a person out. What are their needs? What's making them feel a certain way? And in the event that we hear a call that requires referrals into community support services, we have a list of resource libraries, a resource library in our office that we can connect you to. In the event that these calls come in during day hours, we will make those warm transfers. For example, if a person calls 988 and is experiencing high stress because they are about to lose their home or they cannot make payment for some of their bills, what we can do is make those warm transfers to community support services out there, such as ROP's office, the Division of Homelessness Assistance and Poverty Prevention, to have those introductions and introduce them to see what kind of services are out there to help them address some of their immediate needs. So that's something that 988 does. And also we do activations within the community through our partners at Mobile Crisis Response Team, our 911 dispatch team, and our Guam Police Department dispatch team, depending what the needs are. Because there are certain times where in the event that a call comes in that does require safety, to address safety, we will loop in our GPD partners to cohesively address the situation. Next slide, please. Oh, yeah. The access points to 988. You can access us 24/7 through 3 access points. You can call us at 988. And just a brief introduction on what if a person calls 988, you'll hear a recording, and that recording will sound something like, if you are an active duty service member, a member of their family, or a veteran, please press 1. If you press 1, that will direct you to the Veterans Crisis Line. I will tell you the Veterans Crisis Line is connected off island. It's not handled locally. And then it will tell you for a local crisis center, please stay on the line. If you want to bypass that recording and you want to be connected to your 988 local office, just press 0, and that will bypass the system and you'll be connected immediately to your local crisis center, which is on Guam. You could text us at 988, no matter what your carrier is, if it's Docomo, GTA, IT&E, AT&T, off-island service providers. If you text 988, you'll get a couple of prompt questions, and just follow those prompt questions and it will link you to your local crisis center. And if you want to chat with us online, you could chat with us at lifeline.org. 988lifeline.org, and it's going to ask you to input your zip code, or you could just put that little search bar and it'll connect you. It'll find wherever you're at using your IP address, and it'll connect you locally. This access point is really interesting because we have been having a couple calls from off-island residents to our director's office, and they're former Guam residents. They asked to connect us to the 988 Lifeline here on Guam because they know the cultural relevance that we provide here. They, of course, they're living off abroad, but when they call 988, they're connected to their state wherever they're at. And sometimes when they hear what they're going through, they don't get satisfied from the call because they know that cultures are different from where they're at, from where they're from, right? And so we've had quite a few calls made to our director's office, and it's connected to us. And so that's something to be proud of your team here. People call us from off island to access our local services and our local helps. And also an interesting point, 988 is only 3 years old. Of course, the law was passed in 2020, but it was implemented in 2022. Since then, Guam has had over 30,000 crisis interactions. 30,000. To put that into context, 1 out of every 5 individuals will experience a mental health crisis at any point a year. 1 out of every 5. So you look around the room, right? And I spoke at a forum for contractors a couple weeks ago. It was, to my surprise, that the construction industry has the highest rates of suicide in any work industry in the world. And I told them, you're all sitting in a room in a circle table. 1 out of every 5 individual will experiencing a mental health crisis. So let's not be contributors to someone's bad day. Let's be kind. Let's be help seekers, help lenders. And what you can do to help others in crisis is to link them to 988. Put 988 on your phone. And we're available 24/7. And yeah. Anything else? Okay.
Thank you, Jess. I also wanted to point out that Jess is naturally more artistic than most of us, and so his slides are a little more visually appealing. And so all subsequent slides are not a reflection of our inability to be creative. They're just a little more black and white. Before we start here, by show of hands, who's heard of the acronym GPD? Majority. I hope everybody. Who's heard the acronym GFD? Fire. Who has heard the acronym MCRT? So some do, a lot less, right? And so this is just a small snapshot of our island, and we've done some pulse checks along the way and continue to get our outreach and information out there so that people know what MCRT stands for. So moving forward, for you all here, this is us. I am the supervisor of the Mobile Crisis Response Team. As of April 2025, we are island-wide to all persons in need of service who are experiencing a mental health crisis. So our mission statement, there's 3 key points. And the first one is to de-escalate a person in crisis. So what can that look like? You know, somebody's on the side of the road, right? They just appear out of it. A passerby contacts 988. 988 reaches out to our crisis specialist. They consult for activation. Our crisis specialist agrees. They go out and they provide their service. And they look to de-escalate the person there in hopes that we can get to step 2, which is stabilizing the person and preserving the family unit. So that's one of the bigger goals, is to stabilize where the person's at, right? We are a community-based intervention, meaning we are mental health first response partnered with our law enforcement and fire sister agencies in GPD and GFD. However, if we are unable to stabilize at home, then we move through our crisis continuum and we consult our crisis stabilization unit providers for higher level of care and observation. And the third bullet point really is the overarching goal, right? If we're able to achieve this as a mental health agency and community support service, we will look to reduce other systems utilization, right? And so what does that mean? Typically, when you're in a crisis or an emergency, what number do we call? 911. That's not wrong. However, there's now another option, right? There's 988 and the potential for a mobile crisis response versus call a cop, get a cop, which is absolutely fine. Our men and women in blue do great work. However, maybe the more appropriate service at the time is a mental health specialist versus a law enforcement specialist, right? Also, should you call the police, the likelihood of maybe an arrest, right? If a crime had happened, then that just continues the overutilization of systems thereafter, right? Because now there's an arrest, so you got the judiciary system is involved. Then there's going to be the correctional system involved, parole, and you know, you name it, right? However, if we can intercept at the earliest point with the most appropriate response, then we hope to mitigate everything beyond us. Here are our current capabilities. Although I am very prideful and happy to raise our team arm in arm into the first responder ranks, we are nowhere near as robust. However, we have a dedicated team ready to rock and roll. So our current operational hours, we run 2 shifts, 7 a.m. to 3:30 p.m. and 3 p.m. to 11:30 p.m. That's as of September 1st of this year. We were 24 hours when we initially launched. However, the demand was more during normal working hours. However, should the community demand otherwise and the need escalate, then we have the blueprint to fall right back into 24-hour services. What does our team look like? Earlier, I had described crisis specialists and peer intervention aides. So typically our shifts have 2 to 4 team members per shift, led by a lead crisis specialist. They operate minimum of 2 persons per activation. And in total, in servicing our island, we have 12 direct service providers, plus myself. My team is well-trained and motivated to provide the service. They operate independently of me. The only time I'll really get out there is if I need to act as a liaison as we partner with other agencies on site. We do have access to 2 vans, so we can activate simultaneously if needed. And again, as just mentioned, and I mentioned earlier, 988 is our primary access point. You know, they help us many ways, but one of the more important ones is they're the first step oftentimes, and they're already de-escalating it at their level. So as many activations as we get, they have already de-escalated 2 or 3 times more than that, right? So we really appreciate 988. I was going to say next slide, but that's me. Okay, so as mentioned earlier, right, we are integrated with GPD and GFD via MOU as it comes to crisis response to persons in need of service. And there are several levels of how we achieve that as a team. And so we have here, right, the top level there is telephonic triage. So again, 988 They get the call. The nice thing is that they are integrated with 911 and police dispatch. And so they know that at their level, whatever the call is, if it's safety, they know, okay, I'm going to warm transfer this call directly to GPD because this got to get GPD, right? If it's medical, same thing, GFD. And then, vice versa. So oftentimes when 988 intercepts, they activate us and then we do what we do. So level 3 is mobile crisis activated alone. That's our goal as an MCRT, right? Is to handle the person in crisis on our own and not have to rely on other services, because we know other services, their primary duties are law enforcement and medical. Level 2 is mobile crisis in lead. However, what our team will do, they'll either put like a precinct or a fire station on notice and say, hey, we're activating to a crisis in your area. There's potential for medical or safety concerns. Could you guys at least be on notice? Or would you guys be on standby on scene for us in the event we need your assistance? Level 1 is opposite that. It's either GPD or GFD or airport police or park police are calling us. I'm sorry, they're going out first and then calling us to be support in the event that we're needed. And then level 0, of course, is just fire or GPD. And this is just some data points. I won't hit everything, just kind of the big takeaways. So activation points, as you can see, more than half in the blue are handled by our Lifeline specialists. Otherwise, in the absence of 988 or the absence of an MCRT, that would obviously be absorbed by 911 and flooding those lines. So really happy to report that. Other activation points are our partners, first responders. Activation levels, as I stated, level 3 is our goal as an MCRT, and that's to handle the situations on our own. So you'll see in green, 75% of the persons that we activate to, we are de-escalating and stabilizing on our own. Here are some presenting concerns. So like, what's the primary issue or challenge at the time? In orange, you have 62% are mental health crisis related. And unfortunately, not as high, but still too high for our island or anywhere. In blue is 34% is due to suicidal thoughts, homicidal thoughts, things of that nature. And then contributing factors in the orange, right, is medication noncompliance. So to put that into perspective, if you have a law enforcement officer who's maybe doesn't have the information on the client who's maybe on medication, and responds to a disturbance, and without that information readily available, there's the potential for that to result in an arrest, and then the systems just keep on going, right? However, when we're able to respond with the information we have, and based off of this data, which is a good majority is medication noncompliance, the other contributing factors are typically distress or domestic relational type situations. And then, of course, substance use. Here's our crisis stabilization. Also very proud of this statistic. In blue is just a little over half, 51%. We are actually stabilizing persons in need of services at their home and preserving the family. And those situations where we're unable to do that, then our stabilization unit team does a great job. So that's about 25%. And then we're looking at transportation. Again, our goal is to handle it on our own. So 58% of that, we are not, or we are doing it ourselves and not burdening other entities. However, first responders, when needed, have been very helpful.
Sorry, I wish the mic liked me, but hi everybody again. I'm Alyssa Roberto. I'm with the Guam Systems of Care intake team. So going off of Jesse's 988 program, somebody to call. Mark's program with mobile crisis, someone to respond. With our team, we're that someone or somewhere to go. So our mission is to provide access to treatment through screenings and intake assessments, to determine levels of care, outpatient or inpatient, by consulting with clinical providers and referring consumers to appropriate programs. But you as the audience, I'm sure you guys just want to know what does an intake look like? What does intake mean when somebody comes to the department, they want to seek services, and we always tell them like, oh, you need to do an intake first. Sometimes when people want to seek treatment, it really is a big step, calling 988 or having somebody come to your front door and say like, we received a call and we just want to check in with you. And then coming into our front doors as well, that's a really big step for somebody. So to kind of explain the process of intake with you all, it's really coming in for us to meet with you, to see where you're at, see where this client, this person is, understanding that they might have gone through some hardships. They might have gone through several factors that are kind of like, sorry, I have to get my wordings right. But they might be going through something that's making it hard for them to function in their daily activities. So it's hard to go to work. It's hard to go to school. It's hard to do things with your family that you once used to. So we take in all of those factors, identify what levels of care they need. So when we say, do they need inpatient treatment? Like what are they safe to go home at this point? Or do they have like protective factors where we're able to do a safety plan with them and have them participate in outpatient treatment like counseling, maybe see a provider to get on some medication? Do they need a social worker to help them get the things that they need at this point in time? So that's all of the information that we gather at the intake will help us determine what kind of treatment that they need. And then we refer them to the outside, or we refer them to those necessary programs to help them. So looking at our capabilities, we are a 24-hour program. So our department is open every day, and we are there to receive you, like whether you're in a crisis or you're just wanting to start treatment for the first time. Sometimes people sometimes people have referrals. So if it's from your primary doctor, if it's from your school, if it's from maybe probation, you can bring those referrals over to us. We have several shifts so that we're able to meet everybody at those after hours times. And we have about 1 to 2 intake workers in the after hours. We're open even on weekends and holidays. Again, because whenever somebody's in a crisis, we want to make sure that we're there to assist you. So not just our intake team, but 988 and MCRT, we operate on those times to make sure that someone is there to respond during a crisis. So that's our intake team.
Thanks, Allie.
Okay, so what leads from all of that, so 988 mobile crisis intake, is leading to if you need to have acute crisis stabilization and into admission into our acute crisis stabilization units. So we do have an adult crisis stabilization and a children's stabilization unit. Our children's unit for this year, we serviced about 53 admissions from January until now, and 191 for our adults up to date. Well, a little more because I just had a couple of admissions this morning. You can go to the next slide. The very first thing that I do with the crisis stabilization is I always offer a voluntary admission. So a voluntary admission is when the consumer agrees to be admitted into the unit for stabilization. So first and foremost, we determine whether or not they need to have a medical clearance. So individuals who may need a medical clearance are those who are not known to us. So new consumers who I am unsure if they have any underlying medical history. I also don't send every single person for a medical clearance. Some of them who are within a range where I believe that a first psychosis could occur. kind of maybe would be able to bypass that process. However, there are certain age ranges. If you're an older adult in your 40s, 50s with new onset psychosis, sometimes it's a lot less likely to be a psychiatric disorder. And there are medical conditions that can mimic a mental health crisis. So things like strokes, blood sugar issues, severe sepsis, or that's like an infection in your blood or overwhelming infection that takes over. Those things can also mimic a mental health breakdown. So we want to make sure that the big, scary, ugly medical things are ruled out before we're admitting you into the crisis stabilization unit. Next slide. So if you do not want, or the consumer does not want to be on a voluntary basis, but somebody feels that they could benefit from an acute crisis stabilization, we do have an involuntary admission process. During the involuntary, anybody can petition for an involuntary hold, or it's sometimes called a 72-hour hold. So friends, family, the police, intake workers, it doesn't matter who, but there's like on the top part, next one. On the top part of our form, anyone can make that petition. And once someone makes that petition, I do ask that that person remain available for me to, or whoever our provider is at that time, to provide some additional information. So usually I'll ask them to just remain there until I can speak with them to kind of gather some information about what you're seeing or what the patterns have been that you're warranting or wanting this person to get help. By law, GPD is the only one who can restrain an individual and bring them in for this involuntary hold. So some people think, well, you know, you're Guam behavioral and mobile crisis. Why can't you just throw them in your van and bring them over? Unfortunately, Guam law does not allow us to do so. So a peace officer can be the one. And so that's why we have to work hand in hand with GPD in doing so. And then once they come in, once the petition's initiated, I have 30 minutes to get there, or my providers, to make that determination for whether or not I'm going to admit this person on an involuntary hold. Our criteria for involuntary admission is very strict: harm to self, harm to others, or gravely disabled. So if they are not demonstrating any of those three things, I cannot legally keep them against their will in my unit. Once the petition has been signed, I then have 72 hours, not including weekends and holidays, to evaluate that patient on this involuntary admission. If at the end of the 72-hour period and the person's not stabilized yet or converts to a voluntary admission, then I have a decision to make. I can either petition to the court system for a 28-day hold, meaning I can keep them for an additional 28 days if the court approves it, or I have to release them back into the community. The involuntary hold does also not mean that I can involuntarily make people adhere to medications. I'm not legally allowed to give people medications without their consent unless it's for an acute stabilization or like an as-needed basis. I'm allowed to give a dose of medication for that. But if a person comes in and says, I do not want medications, I have to respect that decision that they're making. So that's our 72 and our admissions. I just also want to say that sometimes we do get referrals from the hospital already, or if Guam Fire is involved. So if GFD is involved, if for some reason the family members call 911, GFD comes out to the scene, they have their own protocols of where to take people. So sometimes people think, I called the fire department and I just want them to come to Guam Behavioral. Guam Fire dictates that they have to go to the nearest emergency room, so they can't bypass their own internal processes and bring them to us. So some people also get a little bit upset, like, we just wanted them to come to Guam Behavioral. We didn't want them to go to the hospital. Just know that that's not my doing. That's their own internal processes from other people. And I'll roll right into our AOT. So AOT is our assisted outpatient treatment. This is a Guam law. It's maybe called, some of you might have heard it, it's called Baby Alexia Law. This law is a way for us to use the judiciary and the courts in a non-punitive, non-criminal way. So it's what we call a civil commitment order. Basically, in the civil commitment, we petition and bring individuals who we deem as maybe what we call high-risk utilizers, or those that might not have been adherent with our treatment plan, so not adherent to medications, consistently coming in and out of a crisis stabilization unit, or maybe having run-ins with the legal system and with the law. So with assisted outpatient treatment, it's a community, like an intensive community-based treatment. The way it works, you can go to the next one, is that we petition through our director, we petition to the Judiciary of Guam through the AG's office to have the individual be under this assisted outpatient treatment. The court, within a certain time frame, will set a hearing and allow us to petition to the court to allow us to bring this individual so they can answer to the judge and to the treatment team. And kind of the goal is to divert them from being incarcerated or divert them from picking up criminal charges and to make them more willing to be on their treatment plan. And so there's specific criteria that's outlined in the law, and I'm not going to go through all of this today, but just know that there is a process in place and we are working towards this AOT to help bring everybody to the table and come up with a creative way to get people engaged and adherent and on the treatment. So when you're initially on the AOT, it's initially for a 6-month period. And with that, you have court hearings, you answer to the judge, you answer to the treatment team, and we really brainstorm and try to help you out with being on your plan. Now, this can be extended for longer. It can be up to a year, 2 years, depending on how you do with the AOT. The reason why I don't want to go too much into the nitty-gritty details is because one of our senators, Senator Shelley Calvo, just introduced a bill to kind of modify and expand some of this AOT requirements. So I don't want to go and make all these promises and then it's all changed right away, but just know that Guam Behavioral is working through these changes to help implement and get another alternative to get people into care. That's kind of what I already went over. I was ahead of my slides.
Okay, thank you, Dr. Carla. I promise this is the last slide, and then I'll just share a couple of activation successes with you all. But I really wanted to applaud myself because I created this and it took a long time. Jess even asked me last presentation, do you still want to leave this in here? I said, of course. So it took me a minute, but this is just kind of a visual and I like it because it just shows, right? We're here to present our crisis continuum and it's this flow, right, of opportunity to intercept persons in crisis in need of help, right? It keeps going. And at any point, one of these intersections, right, it can be de-escalated, stabilized, resolved at that level. And so again, if you were following kind of our flow, right, it starts initially at the dispatch level, which again, via MOU is 988, 911, and or GPD dispatch. They get the call and they do a warm transfer for the most appropriate service. The most appropriate service is typically activated first. And then if it goes to MCRT, we go on our activation, again, with the mission to de-escalate, stabilize, and reduce systems utilization, which also could include outpatient referrals and other community services like some of you in here. If we are unable to de-escalate at our level, then the next level, again, these are all safety nets, right? Is consulting our provider, our team of providers like Dr. Carla. And if it meets the criteria that she just described, then there's a case-by-case potential that client's first going to need medical clearance. But again, that's provider discretion and case by case. So it's not like the older days where it was just kind of mandatory. And then admission and stabilization under a close, watchful eye and caring heart by our stabilization team. So, and then at the heart of all of that is our intake crew, because they're literally camped out there over 3 shifts, 24 hours a day, 7 days a week, weekends, holidays, everything. Just on standby should you or anybody else walk through that door. And real quick, so I'm just going to provide a couple of positive activations so you guys can kind of see or hear how it ideally can work. So one activation was a call received through 988. GPD was already on scene to a domestic disturbance. GPD going through the activation levels. Well, let me back up. First, they did their assessment and decided that, you know what, one of these people here appears to be a PINS, a person in need of service, is what GPD will typically classify somebody experiencing a crisis or emotional distress. So they went through their process, activated us. We came out, noted that, you know, the PINS, the person in need of service, appeared to have a medical condition. So GPD did their process, cleared the person. Fire came, did their assessment and treatment, cleared the person. What did that end up leaving with was MCRT. We took that person where they needed to go, and that was our stabilization unit. So that's one example from 988 through our system partners all the way through our stabilization unit. Another one was our Tumon precinct partners had responded to another domestic disturbance where this person, again, appeared to be a PINS. They removed the person, de-escalated the situation, got back to the precinct and you know, did further investigation. And in doing so, realized we think this person's suffering from a mental health crisis, and maybe these outbursts are related to a mental health crisis or something. So they contacted our MCRT. We consulted. We said, sure, we'll do our assessment. We'll get out there to you. Sure enough, a consumer of ours, and we were able to take that person from GPD's care, reducing their system again, their downtime, the potential for maybe an unnecessary arrest at the time, and take this person where she needed to go, which was stabilization. And then the last one, this one's a little bit deeper in that we get a call for a distressed person, 988 does. This person is standing on the ledge of the Harmon Cliff Line and in significant emotional distress, talking to 988 Lifeline, saying it's over. 988, as Jess said, opened the door and said, hey, we have a person that you need to get to quickly. Our team, luckily, the Harmon Cliff Line, the Oka Overlook. Yeah, sorry. So Jonestown Overlook. There you go. Thank you, my man. Luckily, it's very close to our main facility there in Tamuning. So our team spun up real quick, got out there, sure enough, walked the trail, and that person was still on the ledge, was able to hear her out and hear her off the ledge. And then we were able to get this person back, stabilized in the unit, and then connected to our outpatient, our adult outpatient services. So in a nutshell, those are some of the successes of what our crisis continuum looks to provide in the community. And, you know, we're happy to do it, and we're happy to be here. Again, Chief Rob, thanks for having us. With that, sir, it's on you, and also open to questions if we have time.
So were there any questions in the crowd? I may just have one, just as far as our summit goes for street homeless. How much interaction do you have or have you had since you've been active?
So unfortunately, I don't have that data on me right now, but it is the homeless population does make a significant make up a significant portion of our population.
for 988, we do get interactions from those who are experiencing homelessness because it is a component of deep stress, right? Wondering where you're going to sleep at night, where your next meal is. And so I'm glad that they're help seekers, that they're reaching out to 988. I would encourage. I didn't realize it was off. Uh, lean into your support services. We're here for you. I know homelessness is such a complex journey, and it needs to be one that is very individualized. And I can promise you from the Guam Behavioral Health side that we do our very best. The reality is that the need is out there, and the resources out there are incredibly limited, right? It's hard to say to refer someone who needs a bed to go where there's no more beds left at the shelters, right? And so please please reach out to us. We're here for you. And if you can, I've noticed that a lot of folks that are experiencing homelessness, I always tell them, if you can find Wi-Fi, connect with us on 988lifeline.org or come to us at Guam Behavioral. We're open 24/7 and you can access our services 24/7.
Thank you, Jesse. It's great.
Yes. Yes.
Okay. What happened if, with the 988, okay, what happened if this person is homeless and this person doesn't have a phone or anywhere to contact or money to get on the bus to go up to you guys for help? Do you guys go out to your outpatient clients to come and see them if they need the medication and stuff like that? Does any of you guys go out to your clients?
I know when it comes to accessing 988 services, you have to have some sort of connection, telephonic connection, right, or internet connection. We're not at that point yet by the FCC to make it free for phones to be able to text for free to 988 or call us for free without using your minutes. But that's a national movement that they're moving towards. In fact, in my call with SAMHSA last week, is that they're gathering the data from crisis centers to petition the FCC to make it mandatory for all phone services to make it free. We're not there yet, but we're hopeful that we get there sooner than later. But for the outpatient perspective, you want to?
Real quick though, so from MCRT standpoint, unfortunately, no, that is not part of our mission to go out to people in the community and transport for reasons other than if you're in a crisis.
From the treatment perspective, if you are an outpatient consumer and you have a lead provider assigned to you, I know that the lead provider usually tries to accommodate you and try to find where your most frequent location could be at so that we can continue having appointments or scheduling it in a certain way to identify how we can get bus passes for you to come to your appointments, trying to find you to do some appointment reminders. So on that sense of an outpatient treatment, we do try to work with you at where you're at.
Okay. You guys answered my question. Thank you.
All right.
Anybody else?
Ms. Karen?
I just have a couple of things. So if there's a crisis after 11:30, then do the police just take the person to mental health because the response team can't come out?
Yes, it'll revert back to 911, GPD, and GFD response.
Okay. And then the other thing is if if the mental health crisis is because of a physical problem, like Alzheimer's, for instance, then, you know, where do they get help? Do they get help at mental health? Do you deal with those things? And especially, I'm with Vero, so we've had a person be abused by someone who has Alzheimer's because, you know, because they are not in a good mental state. And they were a little confused about where they should get help.
Yeah, so that's an excellent question. And for those that may not be familiar with Alzheimer's or dementia, it does mimic a lot like a mental health disorder. Individuals can become aggressive, have personality and behavioral changes, and they may also experience auditory and visual hallucinations. We do service those individuals with medication management, usually in our outpatient setting, but I had a few which needed acute crisis stabilization. That is really truly a gap in service on this island. And I know the Lieutenant Governor is also very aware of that. In the mainland and in other jurisdictions, they have dementia centers, which would be the place that these individuals could get. But because we don't have that service here in Guam, you know, utilizing what little resources we have here is how it's best met. So it's usually a combination of management with the neurologist or, you know, the brain doctors combined with the mental health professionals to provide services to these individuals.
And if somebody calls like this, I mean, this was, I don't know, maybe 9 o'clock at night. So it would have been during your operations time. Who can call you? I mean, can the caretaker call you because this is happening? Can Barrow call you because they told us it was, I mean, who can get you?
Yeah, the point is anybody can.
Okay,
The activation point can occur in any way.
okay. Thank you.
So for the activation, we just call 988. Okay, thank
Yes.
you.
Yes. If I can also add, so Guam is part of the National 988 network. And so in the event, let's say, for example, our phone lines go down, or our systems go down, or if all my staff are in current crisis interactions, the 988 network has what we call a backup center in which all incoming calls are routed to that are waiting to be seen. So in the event when that happens, it's routed off island. But because there are protocols that we've established with them, they know when to reach out to us at our local crisis center, and they'll endorse us crisis calls that come in. In the event that does happen, it will be endorsed to us, or what you can do is just call again and just press 0. Those, if you're trying to access MCRT services, it'll come through 988. But if I can also add something to be proud of for the 988 team, a vast majority of our crisis calls and our interactions that come in are de-escalated at that point, meaning that they're not needing MCRT or crisis stabilization or intake services. My team is incredibly trained. I watch them and I sit with them every day, and I watch, and I hear them and watch them interact with the crisis calls, and I'm super proud of them. I'm a fan of their work and what they do, and they're really caring individuals. And so, for anybody who feels a certain way, I tell you to call us, give us a chance, even if it's just to say, hey, a vast majority of our crisis interactions start with, I don't know if this is an appropriate call, but this is what's on my mind. And then we'll navigate those conversations together. And so if you feel like this is something that you don't know if it's 988 worthy or whatnot, just give us a call. We'll figure it out together, but yes, a vast majority of our calls, our crisis calls, are handled or de-escalated at the 988 level. So it's working.
Awesome. So thank you, Jesse. Thank you, behavioral team, MCRT, everyone. Go ahead, give them a round of applause. All right, so now we're at 2:36. Based on the agenda, we should be going to breakout sessions, but we can take the break time you guys need. There's going to be a quick program change. If you look at this first session for the youth and homelessness session, we're going to keep that in this main hall here. So if you want to go to that session, stay here. For those who wanted, our folks here that wanted to take part for the employment workshop and application workshop, go head to room 106. It's out the door to the left. And then also those who want to take part in our lived experience town hall, I'll be there, and we'd love to hear about your experiences and what the coalition is doing for you. So meet us over HSS 104 again. So thank you, everybody.